Postpartum hemorrhage video. The thing with postpartum hemorrhage is that it could be occult and hidden. And so with the delivery, estimating the blood loss and how much of that is amniotic fluid, how much of it is just blood, it's more difficult in the tub, but out of the tub, if there's gushes that keep coming or a continual flow or even a trickle that appears to be maybe blocked by something from coming out. So it's just a continuous assessment of EBL before the placenta is born, and then also checking fundal height. So if the fundal height starts rising, then I know there's occult bleeding inside and maybe the placenta is blocking it. If it's like 150 cc gush, then I'm probably going to test fundal height and firmness and start. As long as it stops, I'm not going to worry. If it's continues to have gushes or it's just a continuous flow, then I'm going to request Pitocin, do 10 IUs in the thigh, and we can alternate thighs and do up to 4 IUs of Pitocin, or 4 doses of 10 IUs. But if the bleeding is not affected at all, then I'm looking to move on to misoprostol and give that a few minutes. And then if that doesn't work, I'm going on to Methergin. I'm getting an IV set up, and depending how much PIT we gave intramuscularly, putting some in the IV fluids as well. So looking for symptoms of shock, having an assistant administer those drugs or actually the assistant can't unless it's a licensed midwife. So having it drawn up, having the assistant hand it to me and me administering it, having the assistant checking the fundal height and monitoring pulse and blood pressure, all of those things need to be happening. So specifically, I'm looking for, if the bleeding is 500 cc's in the first hour, that's considered normal. But if it reaches 1,000 or greater, it's considered a hemorrhage. If I'm seeing 500 well before of the first hour is up, then I'm going to be more active. So before the placenta, I'm doing Pitocin, actively delivering the placenta, so having mom push and doing some cord traction, and followed by fundal massage. And then if there's severe bleeding and the placenta is not coming, so severe, the way I've had it described to me that requires manual removal is it looks like a milk jug tipped over and glugging out blood. I've also seen after a placenta it looking like a garden hose with the thumb over the end and spraying. So I know what too much blood looks like. And I try not to be gun shy because normal physiological, up to 500 is very normal. Some people will still be symptomatic even with 500, but if they're well hydrated, well self-hydrating, I can encourage that. And or I can give an IV and we could treat symptoms, but it's getting the blood flow to stop. And that's important. So before the placenta, the only medication I would use is Pitocin. I'm not comfortable with other ones. There's also different herbs and things, but if I'm that concerned, I'm just going to go straight for the Pitocin because in Washington I can. If a mom is concerned, I could automatically give her the shepherd's purse, yarrow, what else? Motherwort, blue cohosh, Angelica is ground ivy or Angelica is good before the placenta. So any of those that can help. And then after the placenta, if the placenta comes and there's a significant gush with that, I'm usually pretty okay if it is just that single gush and then it's not active, at least for 10 minutes or so with like no bleeding, then I'm not quick to give anything, but just keep monitoring. And I'm super gentle with my fundal assessment, unless I don't feel a firm fundus or unless there's active bleeding, then I do a firm massage. But so if the placenta delivers, then it's Pitocin times 4, alternating legs if needed, and that's 10 IUs intramuscular, fundal massage, and then misoprostol, 600 to 800 micrograms, and I like delivering it buccally instead of rectally because I feel like rectally is just uncomfortable and awkward, and vaginally it's likely to pass out with the bleeding. Bimanual compression would be next, or Metrogen, or I'm doing bimanual while the Metrogen's being drawn up, and bimanual I'm going in to the vagina and getting a fist against the uterus and then at the fundus and holding tight and just holding it until it's firm. Right, and so then the Metrogen is happening, and that's 0.2 milligrams IM. And then I'm getting the IV started, so that's where my assistant is helping me, handing me all these medications and getting the IV started and taking pulse and taking blood pressure, monitoring for shock. And if only 20 IUs of PIT have been given intramuscularly, then I can put another 20 in those IV fluids. So that's kind of the step-by-step. If none of that works, I'm calling 911 and doing aortic compression, which is getting mom flat on the floor or a large cutting board underneath her and pushing the abdomen all the way down to compress that aortic artery, and that's all the way by the spine. So that's the rundown of steps. A lot of women can tolerate quite a bit of bleeding if they are well nourished and well fed, and so that continuous urgence of drink, especially during labor, but also right after, electrolyte replacing, lots of fluids, and then eating something significant with some protein in it as soon as possible can help all replenish that. Herbs I mentioned a little bit, can do a tincture with yarrow and shepherd's purse, or I can do a tincture with blue cohosh, shepherd's purse and motherwort, or another tincture option that I might carry is blue cohosh, witch hazel, valerian, or lady slipper. And then, like I said before, the ground ivy and the angelica is especially for before placenta and there's bleeding. And then just plain shepherd's purse works, or plain yarrow, or plain witch hazel. There's also homeopathy. I'm not as familiar with that, but I have a long list of homeopathics that I can carry. And then treating symptoms. So encouraging mom to rehydrate, like I said, and eating IV fluids. I would do the 100 milliliters of normal saline. Breast, continue to monitor vitals until they're normal and mom is able to get up without passing out. So evaluating the need to transfer. So some women, we could stop the bleeding, and then 2 hours, 3 hours later, they're still not able to get up without severe dizziness and passing out. So then they would need to transfer via ambulance for recovery. Definitely taking a hemoglobin and hematocrit, if not that day before I leave, but at the 1-day visit to see what it is, get the EBL as soon as possible, inspect the placenta as soon as possible to make sure there's no retained parts. So yeah, in order of likelihood, it's tone. So all of the things I've said were to get the uterine tone tight to stop bleeding. The tone, trauma, checking for lacerations, tissue, if there's retained parts, and thrombosis, or that there's actually a blood clotting thing going. And if we're all the way to thrombosis, we're definitely a transfer. The other thing I wanted to point out is not only getting the hemoglobin and hematocrit, testing for that, but also that afterward bringing the case to peer review, so that I am making sure to keep doing quality control and making sure that I handled it correctly and improve where I need to. So that's my rundown of postpartum hemorrhage.